I warmly welcome you to HNF's CME today, which is on the mild traumatic brain injury, as well as what is the GP's role. As you know, Home Nursing Foundation is the largest home healthcare charity in Singapore, and we have been serving frail and vulnerable homebound patients for the past 47 years by providing home medical care, home nursing, therapy, as well as home personal care. We have 2 senior care centers and community rehab wellness at Hougang and Buangkok to serve the needs of the dependent and well seniors in the community with the aim of improving their function, health, and well-being. We are very privileged to be organizing a series of CMEs to serve the long-term care sector as well as home-based care professionals so that together we can improve our capabilities to care for your patients and empower them to live joyfully in on the QR code link. And we also welcome you to attend our caregiver conference that is conducted on the 6th of October this year at Suntec Convention Center. Please sign up and register. And if you are able to turn up in person, we would love to have that conversation with you. And lunch is provided for those who are turning up in person. As we launch our care path on caregiver support in the community, we would like to build a community of caregivers who are able to provide sustainable and joyful care to their care beneficiaries. This afternoon, we are very glad and honored to have Dr. Chan Lai Gwen, who will be sharing with us, and I will be providing a brief introduction on Dr. Chan Lai Gwen. She's a senior consultant psychiatrist in Tan Tock Seng Hospital and also the director of CLIMB, the Consultation Liaison Interventions for Mind and Brain, which is a collaborative project for screening and intervention of various neuropsychiatric disorders. Dr. Chan completed she graduated from NUS Medicine and also her specialty training in psychiatry here. She did her fellowship in the neuropsychiatry of traumatic brain injury .
Hey, hi, Christina. Hi, everyone.
Hello.
Sorry, I just wanted to check for a while because I kind of lost Christina's audio for a few seconds just now. Is it, can I just check whether it's your end or my end?
I can hear you perfectly now, and I wasn't aware that that my audio went off earlier.
Okay, let me just check with your colleagues. Shireen and Kathy, was there some lag just now? Because if there was, then I will reset my router first.
Hi, Dr. Chan.
Hey, hi.
Yes, I think the reception was lost at Dr. Christina's and earlier. So everything looks fine right now on your end.
Okay.
Okay, so I think it was my side. Yep, I think you're good to go.
Can. All right, great. Thanks so much.
Thank you.
Okay, good afternoon, everyone. Thanks for being here on a Saturday afternoon. And I don't know whether you were here for the earlier webinar on non-motor symptoms of Parkinson's disease about 2 months ago. If you were and you are back here again, thank you and welcome you. And just to set moderate expectations, today is not going to be as content heavy as it was the last time. Okay, so don't worry about that. Okay, so without further ado, let's start. Okay, so first of all, I'm just going to do a quick check-in with you guys, and I'm going to set up a poll, and maybe you guys can tell me which of these 4 patients are likely to have had a traumatic brain injury or a TBI. Is it 1, a pedestrian whose head got knocked by the arm of a car park gantry and is now distressed and crying? Or someone who was found unresponsive on the street and woke up confused and refusing to get on the ambulance? Or is it an elderly person who fell down in the home toilet and is now feeling giddy and nauseous? Or is it a jogger knocked down by a car, didn't lose any consciousness, but is bleeding profusely from a gash on the scalp? Yeah, so maybe let's have the first poll come up, and then we'll see what you guys think. Okay, I think the responses have stopped coming in. So I think based on the poll, I think most of you are tied between option 2 and option 3, which is someone found unresponsive on the street and who woke up feeling confused, and an elderly person who fell down in a home toilet and is now feeling giddy and nauseous. Okay, so let's continue. Okay, so actually there are many different definitions of TBI out there by different organizations, and I've kind of listed them down here for you. But if you look in the middle column that I've boxed out in the red box, you will see that what is in common among the different definitions is, first, there is an external physical force that has applied mechanical energy to the head. Okay, that's the first 2 points. And then the third point is that there is physiological disruption of brain function. Okay, so the external force applying mechanical energy to the head, causing physiological disruption of brain function. Okay, and if you look at the factors, and I think most of us are very familiar with the GCS, the Glasgow Coma Scale. So most of these definitions will tell you that the GCS is between 13 to 15. Okay, so let's take a look at the definition that I prefer to use and I have been using in clinical practice. And this is based on the 1993 American Congress of Rehabilitation Medicine definition. So first of all, TBI, like I mentioned, is an alteration in brain function at the very minimum, or some other evidence of brain pathology that's caused by an external force. So what do we mean by alteration in brain function? And you can tell alteration in brain function by any one of the below. So any period of loss of consciousness or decreased consciousness, any memory dysfunction that could be either retrograde or post-traumatic, any objective neurological deficit, or any alteration in mental state that could be seen as confusion, disorientation, or even slow thinking. However, this has to be differentiated from altered mental state that was due to either psychological post-traumatic shock, some concurrent medications that have been ingested, intoxication with alcohol or recreational drug use at the time of the injury. Okay. So if we don't have alteration of brain function, then there should be some other evidence of brain pathology. And usually this is seen in more severe types of TBI, where you can actually see visual evidence or neuroradiologic evidence of structural damage. So that's where you will see changes on the CT brain that is usually done at the A&E. And in some other research centers overseas, they do serum biomarkers of brain injury, and that could be laboratory confirmation. But as far as I know, this is not done locally And the injury is caused by an external force, which could be the head being struck or the head striking an object, or an acceleration, deceleration movement of the brain. And this we commonly see in jumpers or people who have been knocked down by a moving vehicle and they sort of have a trajectory of flying through the air before they land on the ground. Or there could also be a foreign body that penetrates the brain, or forces such as from a blast or an explosion, or any other force that couldn't be defined. So this is the current definition that I find very useful in determining whether there has been a TBI. So the important thing to note here that we're not going to be using the term head injury as we used to anymore, but we're going to increasingly use the term traumatic brain injury or TBI because it reflects the understanding that it is damage to the brain that results in the clinical syndrome. And it's not so much the damage to the scalp or to the skull. So just because that there is a scalp laceration or there has been a contusion or a bruise to the skull, or we see a scalp hematoma, so that doesn't necessarily mean that there has been a traumatic brain injury unless it fulfills the clinical criteria. Okay. So in terms of today, we're only talking about the very mild forms of TBI. We're not going to be talking about moderate and severe because most of the mild group do not have structural brain damage. It's more of a physiological, functional kind of injury. And so what happens in a concussion is that these events cause an acute cascade of neurometabolic and neurotransmitter changes, which do require a period of time for progressive compensation and correction. So what happens is that the cells in the brain become kind of leaky, leading to ionic imbalance and release of excessive glutamate. And then because there is reduced blood flow to the brain, there is also a reduced energy supply to the brain. And so the symptoms that we see in concussion are due to these functional disturbances and not the structural damage that you might see on the CT brain, the hematoma, the bleeding, or the swelling. So these would be for the moderate and the severe TBIs. Okay, so now at this point, I'm just going to stop for a quick poll and ask, which of the following do you think is not a sign of altered brain function after an external force to the brain? Is it disorientation? Is it pressure of speech? Is it amnesia? Or is it diplopia? Yeah, can we have the poll, please? Okay, great. I think the responses have stopped coming in, and we can see here that most of you, 37% of you, have answered diplopia. Following that, 34% have actually answered pressure of speech. Okay, so actually the correct answer is number 2, pressure of speech. Okay, so pressure of speech is when a person speaks very quickly, as if it is coming out of a tap that you cannot turn off, and you cannot get a word in sideways. So that's actually psychopathology, a symptom and a sign of psychiatric pathology, normally seen in manic or hypomanic patients. So this is not a sign of altered brain function after an external force to the brain. Whereas disorientation, memory dysfunction, diplopia, which is actually a hard neurological sign of abnormalities in synchronous eye movements. So these are indicative of altered brain function after an external force to the brain. So if a patient has disorientation, amnesia, or diplopia, it could indicate, right, that there has been a TBI. Right, thank you. So let's go on. So now let's look at a specific case history, and then along the way, we'll stop at important milestones to talk about the clinical stuff about mild TBI. So here we have Miss X, who is a 40-year-old lady. She is a divorcee with custody of 3 children, all below the age of 15. She's working as an accounts executive in a small and medium enterprise. She has a past history of adjustment disorder with 1 episode of self-harm during divorce, but now no longer on any mental health follow-up. She's a pedestrian who's been knocked down by a Grab delivery rider who was using a modified PMD. She fell and hit the back of her head with loss of consciousness, very brief, less than 5 minutes. And she went to the hospital emergency and was discharged after the CT brain showed that it was normal. But the next day, she was accompanied by her colleague to your clinic as she was feeling terrible and unable to work. So what would you do? Would you refer her back to ED? Would you give her 3 days of MC? Would you give her 3 days of MC followed by 3 days of light duty? Or would you give her 1 week's MC with education and reassurance about recovery from concussion and advice for re-engagement? Okay, so could we have the poll up again, please? Okay, I think the responses have more or less stopped coming in. Okay, so here, most people, 70% of you would say that you would refer her back to ED, and then followed by some people, about 26%, about 1/4 of you would say that you would give 1 week's MC with education, reassurance, and advice. And then minority, 3% would say give 3 days MC followed by 3 days light duty. Okay, so let's see actually what should be the clinical approach. Okay, so the clinical approach that I would recommend is actually to, first of all, get the history. So now with your understanding of what is actually the definition of a mild traumatic brain injury, first of all, establish that it has indeed happened by asking her for the history of the mechanism of injury and whether it was plausible that a mild TBI has occurred. So you can ask her for evidence of memory dysfunction, which is actually one of the commonest presentations of altered brain function, by asking her what is the last thing that she remembered and then the next thing that she remembered, to look at whether there were any gaps in memory formation around the time of the accident. And then, of course, clarify whether at the time of the accident, whether she was under the influence of any alcohol or drugs or medications, and whether she has had a concussion before, because a repeat concussion actually may be a little bit worse than the earlier concussion. And then ask whether she was able to respond normally after getting up or waking up from the injury. And it would help at this time whether there was any observer history or if anyone had taken a mobile phone video of what had happened at that time. So this would also help you to assess whether there was any evidence of a brief period of altered brain function. And I would recommend that you would ask for the physical symptoms that she had immediately after the injury. So for example, was there severe pain, headache, nausea, any numbness or weakness, unsteady gait, blurred vision? Because this would be useful because as you track the trajectory of recovery and the timeline of the symptoms, this is useful for your follow-up of the patient if she comes back to see you again. So this would be the clinical approach that I would recommend. So actually, most places and most emergency services would have discharge advice for patients like that who have had concussion or mild TBI. And usually they would give some patient information leaflet. And I've shown you here an example from the US CDC, which is discharge instructions, which advises patients on how to watch out for certain changes and actually to schedule a follow-up appointment with their regular doctor, which could be you, right, in your setting. So these are the danger signs and the red flags that patients are advised to watch out for, which would really be things like a worsening headache, worsening nausea, repeated vomiting, unusual behavior, agitation, drowsiness, objective worsening neurology, seizures, or loss of consciousness. So these are essentially all signs of increased intracranial pressure. And in this setting, with patients with any of these things, do need to be referred back to the ED for repeated neuroimaging to make sure that there aren't any delayed hematomas or things like that. So if they don't have these, the information leaflet for patients usually will list down some general advice. For example, telling them what are some of the symptoms that they might expect in the next few days and in their recovery period. And also the reassurance that symptoms will generally improve over time and most people will feel better within a couple of weeks. But of course, there's also advice that if the symptoms are of concern, they're getting worse, they're not getting better, they need to go back and talk to their regular doctor. So some of the symptoms here are divided and categorized by domain. So in the physical domain, commonly they might experience light or noise sensitivity. They might have dizziness, fatigue, headaches, and some vision problems like blur vision, not able to see things sharply and in focus. And then some cognitive problems, that means difficulties paying attention, focusing, feeling slowed down, groggy, and not being able to have the mental or cognitive energy to sustain through an activity. And there might be some emotional disturbances as well, such as irritability, tension, feeling more emotional, and bouts of sadness. And there might be sleep disturbances as well. Either they sleep less, they sleep more, or they have trouble falling asleep. So basically, if there aren't any of the red flags that require a patient to be referred back to ED for a repeat CT scan, the recommendation is that patients should get complete mental and physical rest for about 24, maximum 48 hours. And this rest needs to be taken place in a quiet environment with no cognitive load. That means no reading of novels, no screen time, cut off use of computers, phones, or TV, and no strenuous activities. And after 48 hours for progressive re-engagement. Now, this is the main change from what we knew in the past. So in the past, the advice used to be to rest as much as you need for as long as you need before you feel completely well to go back to your activities. But now the advice based on latest evidence has changed, where you rest for maximum 48 hours and then you start your progressive re-engagement schedule. So in the initial part, when you start to re-engage, you do low intensity activities such as walking or brief light jogging and light mental stimulation, and gradually increase the intensity of the activity until the person is able to resume their normal daily activities. If at any point in time of this process, that activity makes any of the symptoms worse, the intensity of the activity must be temporarily reduced to a more tolerable level before you start to gradually increase again. So essentially, patients are to do something, don't do nothing, and when you do something, you do as much as you can tolerate. And during this period of time, there are two important physical symptoms that need to be actively and proactively managed. And one is that of headache or other pain, and also managing sleep disturbances. So pain, what is recommended is that we prescribe paracetamol as necessary for short-term relief, but avoid NSAIDs and aspirin within the first 48 hours, and also avoid opioids and other sedatives. And as for sleep, it is to prioritize the non-pharmacological interventions to try and improve sleep, and also to advise self-care to avoid alcohol and other recreational drugs. Because what we know is that when there is pain, it puts the body under stress and it increases cortisol levels in the system, which is harmful for brain recovery. And sleep is critical, necessary for neurological rest and recovery. So brief naps in the day are okay, but as much as possible, do consolidate the sleep at night, and preferably using non-pharmacological strategies. So what is actually happening is that in concussion, there is a disrupted neurometabolic state in the absence of structural damage. And what hinders recovery is when there is a lack of initial rest, or if a person tries to re-engage into activity too intensively in the beginning. And if in the early part there are additional brain injury events, then this would hinder recovery. But other than that, what would then promote recovery is that after a period of initial adequate rest, we gradually increase the exercise, because this increases cerebral blood flow and increases the energy that's available for recovery. And it also then increases the production of BDNF, which is a protein that promotes neuronal recovery, until complete recovery and a normal neurometabolic state has taken place. So back to Miss X, okay? So 1 week after that initial clinic visit, 1 week later, she comes again, and because you have asked her to come again for a scheduled follow-up. At this time, she says that she's feeling improved, but she's still having headaches and dizziness, especially when she works for more than 1 hour on the computer. She also has mild difficulties with sleep initiation and maintenance, but in total, she's still able to get at least 6 hours of sleep, which is pretty decent. But she feels conflicted when you offer her light duty or further MCs because things are busy at work. She's an accounts executive, if you remember, and she feels guilty that she needs help to cover her work. And at the same time, she also needs the job to support her family, so she cannot risk having a poor performance review. So there's some psychosocial stressor there. So at this time, what would you do? Would you give low-dose tramadol for headache since it is persistent? Would you give melatonin for sleep difficulties? Would you continue to educate and reassure her about the recovery trajectory and then observe her further? Or would you help her write a memo to her RO informing about the recovery needs and the gradual return to work plan after a mild TBI? Okay, maybe let's have the poll. Okay, so the responses have stopped coming in, and we can see here that most people would choose option 4, which is to write a memo to the RO for her gradual recovery needs. Okay, and then after that, about a third say that we should educate and reassure her about the trajectory of recovery. Some people would give low-dose tramadol, and a smaller proportion would give melatonin for sleep difficulties. Okay. So maybe for here, I would say that mostly I would recommend avoiding opioids for pain management, and then also avoiding pharmacological strategies for sleep. Let's see what is the recommended approach after this. Okay. So actually, according to recent studies that I've quoted here for you, so this is the recovery trajectory that we can expect for mild TBI patients. So actually, less than half of them would have fully recovered by the end of 2 weeks after injury. And even up to 4 weeks after the injury, less than 80% would have been expected to recover. So full recovery, which is about 94–95%, is actually only seen at about 8 weeks or 2 months after the injury. And what complete clinical recovery means is that if a patient has actually very minimal physical symptoms that do not worsen with their normal daily activities, if there's resolution of any abnormal examination findings with good exercise tolerance and a complete return to whatever they were able to do pre-injury. So that would actually be complete recovery from the healthcare provider's perspective. So only less than 95% of patients will be expected to fully recover at the end of 8 weeks after the injury. So who are the 5% or that small group that are at higher risk for prolonged recovery? These will be patients with pre-existing mental health condition. It sounds like Miss X because she has a past history of adjustment disorder, being female, who have had concussions in the past, and people who have great symptom burden in the early part after the injury. That means they were very symptomatic with headache, pain in the body, very dizzy and all that. And then if they had presence of migraine-like symptoms or a history of migraines or chronic headaches. And other potential risk factors are if the patient has predominant vestibular symptoms like dizziness and gait instability, the younger patients as well as the older patients, and people who misuse alcohol and substances. So if you have a patient like that, then you would want to look out for them because they are at high risk of not recovering at the end of 8 weeks after injury. So what do we mean by returning to normal activities? So most of the time we are talking about return to work or return to school, right? Because you might have full-time students. So return to work actually means gradual resumption of their workload, which means that you might need to actually advocate for either flexible hours or reduced hours and gradually building back up to full-time work as tolerated. And so now with this knowledge, you have a runway of about 6 to 8 weeks to actually help your patient plan to gradually return back to their full-time workload. So we might advocate for them to be adaptive in either in terms of working hours or in terms of job placement. So where the task can actually be matched to the person's ability and tolerance, because in the initial period, computer-based work may need to be limited, because too much screen time actually can exacerbate the symptoms as well. And also helping to ensure that the workspace is appropriate for recovery. So it's quiet, it doesn't tend to overstimulate the brain, and so a noisy environment will tend to overstimulate and increase the cognitive load that the patient may be receiving. And also, if possible, try and provide some driving or transportation requirements to and from work. Similarly, in return to school, gradual return to school. So if a full-time student is quite symptomatic and needs that time to recover, so first of all, they start off by performing regular daily home-based activities that are not related to school. So for example, some simple household chores like packing up their room or some simple kitchen work. And then after that, begin to incorporate school-related activities, for example, trying to read a paper or trying to complete a simple assignment or doing a simple quiz, for example. And then after that, gradually return, and that's actually guided by the symptoms that they have and how the symptoms respond to the cognitive load that they're receiving. So it could mean partial days or taking lighter subject load or taking frequent breaks. Now, I know that in mainstream schools, so let's say you have a secondary school student or a poly student, taking additional breaks might be quite difficult. So it might be that you might have to advocate for a shorter school day, for example. So remember, you have a 6 to 8 week runway period to plan for this. So it might be that the student, if he's in a mainstream school, he might have to go home after recess, for example, and then gradually extend the school day until he can tolerate the complete school day. And then when tolerated, they can have a full return to school activities. So the other part is actually returning to play, which is for sportsmen and athletes, okay? So for this one, the actual plan of return to play depends on different sports, whether they're contact sports or non-contact sports. And for this, actually, the sports medicine physician would be more well-placed to actually advise on this because they have specific protocols. But in general, the general principle that I will just go through briefly is that people who sustain a sports-related concussion should immediately be removed from play and enforce complete rest for 24 to 48 hours. And complete return to sport at that level, the sportsman competitive sports level, should not occur until there is return to work or school. So they have to settle return to work or return to school first before they can talk about return to play. So most of the time, we will advise avoidance of contact sport for at least 2 to 3 weeks. So here there is a brief general guideline, which is to start with low intensity exercises, then progressively increasing to non-contact sport specific exercises, then more complex sport specific exercises, then after that being assessed medically by the sports medicine physician before being approved to return to full contact training, right? So this is meant to reduce that phobic avoidance and to build confidence so when the player gradually returns to competitive sports. So let's go back to Miss X again, okay? So by now, it is about 10 weeks post-injury, right? So this is past the 8-week timeline. She's actually come back to your clinic again, and this time not for a scheduled follow-up, but she's come to see you of her own accord. And she rates herself as only 60 to 70% back to baseline. And why does she say that? Actually, in terms of the physical symptoms, her headaches and dizziness have improved by about 90%. So they're very minimally there, but sleep is much more fragmented. She says that she can fall asleep because she's really exhausted at the end of the day, but she wakes up in the middle of the night in a jolt because she needs to finish her office work. She brings her work home to do because she can't finish them in the office. Her children are also having exams, so she does try to spend more time to be attentive to them. And she's also not telling her children what she's experiencing so as not to distract them from their exam prep. So she's been feeling especially more stressed and upset, especially after discovering that the Grab rider who knocked her down is trying to shift the blame to her and has even uploaded a video recording online. However, she doesn't know the details because she has avoided viewing or even talking about the video, but she is upset by this. So in the past, when people were talking about post-concussion syndrome, even the DSM-4 and the ICD-10 could not agree on the specific diagnostic criteria for what is known as post-concussion syndrome. So we can see here in the DSM-4, they put emphasis on the cognitive disorder. It was either major or mild. And it was not so in the ICD-10. So in the ICD-10, there was no emphasis placed on the cognitive deficits. In fact, the cognitive difficulties could be subjective and it need not be objectively measured. And what are the current definitions now of how we frame persistent concussion symptoms after an injury? So like I mentioned just now, in ICD-10, the diagnosis was that of post-concussional syndrome. But in the recent ICD-11 and the DSM-5, again, it has been placed under a section of neurocognitive disorders, right? And that is temporally related to the TBI and that it persists beyond the acute period. So again, in the DSM-5, it does need to be objectively seen cognitive deficits. And in the ICD-11, it can just be a subjective decline in cognitive functions, okay? So essentially what I'm trying to say here is that the main message is we do not use the term post-concussion syndrome anymore because it is no longer considered to be a valid diagnosis. Instead, we talk about persistent concussion symptoms. And we say that it is persistent when it lasts for more than 3 months. And this occurs only in a small proportion of patients, probably about 5 to 6%, at most 10% of concussion patients. And this is where we need to reconsider the differential diagnosis to include assessment of the social support and the potential psychological stresses, and also assessing current medication use, alcohol use, or recreational drug use, which are often perpetuators of the symptoms. So let me give you an idea of the impact that this shift in clinical approach, what that means for patients. So if you look here for patient A, okay, So let's say patient A in the past, where we're using the DSM-4 or the ICD-10 framework, a patient who has all these symptoms that are persisting, headache, dizziness, tinnitus, irritability, sleep disturbances, fatigue, and all that. So if we lumped all these together and explained it away by labeling it as a post-concussion syndrome, then management is limited to reassurance, education, and possible supportive therapy, or sometimes even more targeted psychological therapies. However, if we use the newer framework of just approaching it as persistent concussion symptoms, if we look at patient B, who has maybe prominent headache, dizziness, and irritability, okay? So this could be framed as having a post-traumatic migraine, and therefore this patient can have specific migraine or headache interventions. And the cluster of symptoms, if they have headache, if they have fatigue, anxiety, poor concentration, this could actually be clustered together and understood to be post-traumatic stress symptoms, which are psychological in basis, and therefore provide the patient with targeted psychological therapies. So you can see that management and intervention is more targeted if we use the persistent concussion symptoms framework. Similarly, if you have another patient who has prominent dizziness, this could be framed as having BPPV, and therefore this patient might benefit from vestibular management. And the patient who might be having persistent sleep disturbances, fatigue, energy problems, irritability, you could look into medications and rationalize the medications that she's taking. But if they have other physical somatic symptoms, they could actually meet the criteria for a somatic symptom disorder, and thus requiring targeted psychological therapies for that. So essentially, from clinical experience, what this means is that these physical somatic symptoms after a concussion will actually gradually recede with time. After 3 months, and generally by about 6 months, almost all of these somatic symptoms should have resolved and receded, okay? And even in terms of their objective cognitive performance. However, psychological problems may not be so clear and obvious in the early post-TBI period, but they gradually become more prominent and play a more important role in perpetuating symptoms as time goes by. So generally, after about 3 to 6 months after injury, we're on the lookout for more psychological problems, such as depression, anxiety, PTSD, and sleep disorders. So some of the important differential diagnoses for persistent symptoms post-concussion, I've listed them down here. So we need to be aware and mindful that there could be a PTSD, a generalized anxiety disorder, a major depressive disorder, or even functional neurological disorders or somatic symptom disorders. So I think we are all very aware of what PTSD is, where there is irritability and anxiety that is related to triggers due to the trauma. GAD, where there is generalized anxiety that is not specifically related to the trauma. Major depressive disorder, where there is a persistent, pervasive, low mood, anhedonia, sense of guilt and worthlessness. Functional neurological disorder, where there is a disturbance of a neurological system. That means there's a neurological symptom or a sign that is inconsistent, and a neurological explanation cannot be found for the presentation, and there is distress associated with loss of function from that symptom. If there is a non-neurological physical symptom, it could actually mean that the patient has a somatic symptom disorder. And then the patient usually demonstrates persistently high levels of anxiety and actually have a high awareness and appraisal of their bodily symptoms as being threatening to their overall health. So this is the spectrum of differential diagnosis that we look out for. So in summary, how we approach mild TBI patients is that in the early recovery period, that is less than 3 months post-injury, we give a lot of psychoeducation and assurance of the expected recovery trajectory. We target the symptoms and treat them. We give medical support for enforced rest and then advocate for their gradual return to work, to school, to sport. and offer them psychological support for successful adjustment, and also identify early those who are at risk of being what we call the miserable minority with closer follow-up. Now, if you do happen to pick up patients with persistent symptoms beyond 3 months of the injury, it would be helpful to re-evaluate the symptoms that are actually causing them distress and functional impairment, and then refer them on to be assessed to treat Axis 1 psychiatric disorders and comorbidities. And that is when we will have to work closely with other specialists involved in their care, because they could be referred to a headache neurologist for the post-traumatic migraine. They could also be referred to an ENT doctor to address the vestibular issues, or they could be referred to a neuro-ophthalmologist for persistent ocular issues. There might also be potential litigation issues, and also the social worker might be required for perpetuating psychosocial issues. But basically, by this time, usually a multidisciplinary team and more specialist involvement would be required. So now we would come to, I think it's the last poll. So which of the following about persistent concussion symptoms is false? Is it that they lead to permanent cognitive deficits? Or is it that the presence of a past psychiatric history is a risk factor? Could it be that stress plays an important role? Could it be that medication use may contribute to persistent concussion symptoms? Maybe let's have the poll and see what you guys think. Okay, I think the responses have kind of stopped coming in. Yes, and I think that most of you have got it correct, about 48%. Okay, so persistent concussion symptoms do not lead to permanent cognitive deficits. Okay, do not lead to permanent cognitive deficits. Okay, so most of the time, if there are objectively measured cognitive deficits, there's usually an explanation. So I do not expect migraine or headaches or vestibular problems to give rise to cognitive deficits. Usually it is in association with the psychiatric diagnosis like major depression or generalized anxiety disorder, and even things like PTSD or functional neurological disorders. They are generally not associated with permanent cognitive deficits as well. So if the psychiatric diagnosis is actually well treated, I do not expect for them to have permanent cognitive deficits. Though there have been some case reports of patients complaining of subjective cognitive difficulties a long time after they suffered a concussion in the absence of structural damage. But actually, in most of the time, we do not expect a permanent cognitive impairment, like a mild or a major neurocognitive disorder persisting for so long after a concussion. Okay. So the last bit is really just a couple of slides in special groups. So first of all, concussion in children. Okay. So some things to look out for in children is that children may be less insightful or articulate about their experience or their symptoms, and therefore that could lead to externalizing behaviors instead. So it is useful to actually ask the parents or the caregivers to watch out for the change in behaviors. And because children, especially the younger ones, some of them may still need naps. They may end up napping a lot more. So brief naps in the day are still okay, but do make sure that it doesn't interfere with the nighttime sleep. And I know that in this day and age, it's quite difficult, but it's really important to limit their screen time and their cognitive load, which is homework and tuition, during the gradual return to school phase. Okay. And also important to reduce stress and excuse them from important tests or exams if it's really required. and also suggest activities that actually provide positive reinforcement. That means pleasurable activities that actually give them the confidence to go back to whatever they were doing before. And the last group is actually the elderly. So some things to take note of in the elderly group is that the pre-morbid history and function can be mistaken for post-TBI symptoms. So for example, before the injury, they could have had random headaches, or they could have some mild cognitive decline. So some of these that were taking place pre-morbidly can be mistaken for post-concussion symptoms. So it's very important to be very clear about the history, the pre-morbid history, as well as the timeline of symptoms. And also because elderly people generally have a lot of medications, so do rationalize the medications and beware the effects of polypharmacy. And that's especially important because we want to reduce the risk of further falls at home and in the community, and because that puts them at risk of recurrent brain injuries. So the first one might be a concussion, but the next one might actually be a moderate or even a severe TBI, where there's actually worse structural damage. It's important to engage caregivers to look out for them and observe them very carefully. We do still maintain the aim for full functional recovery, but do give it a bit more time. So they could take longer than 8 weeks in order to regain their full baseline function. So the trajectory is actually important. It's really to make sure that there is a continuous direction towards improvement, even though it might be a bit slower than the normal adult. Okay, and in the meantime, because the recovery might be very slow, do watch out for the development of mood problems as well as anxiety problems, particularly phobic avoidance due to anxiety and fall phobia. Yeah, so do watch out for that and continue to support them and give them the confidence to go back to their pre-morbid functions. Okay, yeah, and with that, I've come to the end and I'm happy to answer questions. Thanks.
Thank you very much, Dr. Chan, for that very insightful sharing. We have a couple of questions. So the first one is from Dr. Yee. Is there any evidence for supplements like ginkgo or nortriptyl to hasten or enhance recovery from minor traumatic brain injury? And along with that, persistent vertigo or otologic symptoms post-traumatic brain injury, are there any medications or management that are helpful?
Okay, yeah. So thanks for those questions. So there actually has been no evidence for supplements like high-dose omega-3 or ginkgo or nortriptyl. So actually no evidence that they will help a person to recover from TBI. The main evidence is actually gradual exercise. Yeah. So gradual return to engagement, aerobic exercise. Now that enhances recovery. In terms of persistent vestibular symptoms, actually it is important to go for investigations to look at the underlying cause and also vestibular maneuvers. So vestibular rehab is very helpful. Yeah, not so much the medications, but actually vestibular rehab is more helpful in managing these persistent symptoms.
Okay, thanks. The next question is around what kind of signs and symptoms should we look out for that will point to a need for ED referral, understanding that many of our patients typically do not like to be sent to the ED. So these are important for us to find out what red flags there might be.
Yeah. So basically the most sensitive symptoms for increased intracranial pressure would be a worsening headache and then recurrent vomiting and nausea. So those would be very important red flags. And then of course the other ones would be quite emergency already lah. So things like sudden fainting, collapse, seizures, but in the elderly it might be a bit more difficult to tell. So I've had elderly who had delayed hematomas. They also had subjective feeling very terrible, but what happened was that the gait became very unstable. So that actually is also a hard neurological sign that we look out for. So any worsening objective neurology would be a red flag to refer back to ED lah.
Okay, thanks for that. We have one last question. Are the terms concussion and mild traumatic brain injury interchangeable? And is there any legal differences if we use one term over the other? And are we allowed to diagnose the concussion or mild traumatic brain injury without neuroimaging?
Yeah. So actually the terms concussion and mild TBI are interchangeable, but like I said, we avoid the term post-concussion syndrome. So that's the only term that we would avoid, right? Post-concussion syndrome. So in terms of legal differences, I don't see much. And actually overseas, primary care physicians are actually allowed to diagnose concussion without neuroimaging. Yeah. So it is possible if you have very good history and if you go according to the criteria that I just showed you, where the mechanism of injury shows that it is plausible for a blow to the brain, altering the function. And then there are these certain instances where there's evidence of altered brain function that you can get from the history. Yeah.
Rest of the participants to sign up for the next installment, which is on the 6th of October at Suntec City, our caregivers conference. It's also available for attendance virtually if you're not able to make it physically. And please join me in thanking Dr. Chan once again. You leave the slide on for those of you who would like to register. And thank you very much for all your attendance and support.
Thank you. Bye-bye.
Thanks. Thank you. Bye-bye.